Welcome to Coffee with Kyle number 7. I am Kyle Ridgway. Good morning. Today I was thinking about behavior change and kind of reflecting on how hard behavior change is, even for us as clinicians or people who are well educated, who have a lot of opportunity or don't have a lot of other very big existential or socioeconomic worries in our life. And it got me to thinking about our patients and physical therapy. And one of the things that kind of strikes me as interesting is, regardless of what setting we work in, every single session, every single day, and every single setting, we are actually requesting, implying, or sometimes explicitly asking our patients to change their behavior, change their beliefs. I talked a little bit about that a few coffees ago, about how cognitive dissonance and other cognitive biases and logical fallacies can actually really make it hard to change our beliefs. Well, now we're talking about the boots on the ground action of changing our behavior. And I think all of us know intuitively and from personal experience that this can be quite a challenge, whether it's creating new habits or breaking old habits. Some of the same cognitive barriers exist to behavior change as they do to belief change. And these things can be hard to sustain. And I think one thing that I always use as an example to think about is, everyone wants to be at a healthy weight, and sometimes we start a diet and we try to change like 17,000 behaviors at once. We try to eat more often, we try to eat less, we try to eat different content, we try to shop differently. And if we break it down to the foundation and the fundamentals, we would realize that, man, that's really we're asking ourselves a large task. Because even though the goal is eat healthier, maybe lose some weight, the way that we're going about it is by asking ourselves or asking someone else to change a lot of behaviors, not just one behavior. The reason I think this is important is we have knowledge of why we need to change our behavior. We have motivation to change our behavior. We probably even have the means and the resources to change our behavior, and yet it is still remarkably difficult for us as practitioners, as physical therapists, as other people who are maybe more well-off or better educated, or even have strategies on behavior change. So I was reflecting the other day on how hard it must be for some of our patients to change their behavior, and how we may have to reconceptualize how we interact, frame things, or structure our rehabilitation to actually facilitate behavior change. And I think there's some really nice concepts out there that help get us along that path. Motivational interviewing, I think, is a tool that can help us drill down into some of the kind of internal motivations or goals of the patient that may actually help drive them to stick to a plan or buy into a plan or be able to sustain behavior change. Models of shared decision making and therapeutic alliance, I think, are very important in this regard as well. But I think it's imperative that we think about behavior change every time we're interacting with patients. Because, like I said, every time we are interacting with patients, we are actually asking them to change their behavior, whether it's to start an exercise program, to change an exercise program, to change training, to try to move in a different way, to try to understand things differently. Sometimes we're even asking or nudging our patients to change their beliefs. So I don't think we can underestimate the profound nature of what we're doing here, as well as how difficult it can be. And if we just reflect internally on how hard it is for us to change our own beliefs and our own behavior, I think that gives us a little more compassion for the patients that we're interacting with, who may be in much more challenging situations. They must be maybe much less more advantaged than us. They may have much less resources for change. They may have a lot of other pressures that supersede what we're actually doing with them in rehabilitation. And a lot of times, unfortunately, we're seeing patients at the lowest of their low. We're not seeing people at a peak of motivation and engagement sometimes, because they're dealing with profound primary losses of function, of roles, of responsibility, of the ability to perform physically. And we want to take that into account. And I think reflecting on the mechanics and the challenges of belief and behavior change can help us interface with patients. And I think what it does, and this is an old quote from Jason Silvernail that I love, is that he said, and I'm going to butcher this, of course, is that as soon as I stopped taking responsibility for the outcome of a clinical encounter, I freed my patients from blame, and I freed myself from guilt. And I think that that is highly important concept to remember. Is we want to be focused on outcomes. That's important, and we want to use those outcomes as a feedback loop for what we're doing. But we don't want to tie our professional identity so strongly to outcomes that we lose out on what the appropriate process is. And I'll leave you with that this morning, some reflections on behavior change. So it was good to see you, and have a great day.